So this is one of the most recent evidence of large studies that showed drug safety, the increasement of drug safety after pharmacogenomic testing. But actually, this has not only since this, it has been for a long time, almost 10 years for some medications that have really shown, and some gene drug medications, that there's a very strong evidence that you need to genotype or to test this gene before taking this specific medication. A study goes back to 2016, so it's 10 years ago, showed that in DPWG gene testing, it's a gene that encodes for an enzyme that detoxifies fluoropyrimidines, and a study that included more than 2,000 patients showed that the genotyping or testing only this gene can reduce the toxicity of these medication or these cytotoxic drugs from 73% to 28%. And the occurrence of drug-induced fatalities was reduced from 10% to 0%. This evidence has been there in the literature for 10 years. And just last, I think it was in November or something late 2025, this has been added to the label of one of the fluoropyrimidines affected by DPWG. Can you imagine? It has been 10 years for this to be added to the drug label, for requirement of testing DPWG before start taking capecitabine, one of the fluoropyrimidines. So we go, so the answer of, is there enough evidence of safety? I think it's yes. Is there enough evidence for pharmacogenomics for improving drug efficacy? This is also has been proved for many long years, so for many years. It has been since 2010 that there's an evidence that tacrolimus, one of the immunosuppressants commonly used to prevent transplant rejection. So it's not like something that is over the counter, not something that is a very important medication for a very critical indication. And so here, usually it is a therapeutic drug monitoring, the common practice. But for this study, they have tested starting before the initial dose, doing a genotyping of one specific enzyme gene that is, of course, encoding for an enzyme responsible for tacrolimus detoxification, which is CYP3A5. And the results showed that for patients who have a pharmacogenomic testing at the beginning of the treatment, 75% of these patients achieved target tacrolimus concentration on day 8 compared to day 25 of patients who didn't receive this test before starting the medication. Also, they found that more patients achieved the therapeutic tacrolimus levels after 6 oral doses. So also, it's 43% compared to 29% in the pharmacogenetic tested arms. The last result from this study that fewer doses needed to be modified. So can you imagine the number of modifications these patients needed? In the pharmacogenetic testing arm were 281 compared to 420. So it has been a very important addition. It didn't cancel the need for therapeutic drug monitoring, which is the common practice, but at least it's lowered the amount of suffering, the amount of the days that these patients needed until they reach the target of this treatment. And we are again speaking about a very crucial indication for a very severe case, which is transplant rejection. So I think you are now convinced that there is evidence of pharmacogenomics that it can improve efficacy, and this has been for 16 years reported from this day we are talking about. So maybe by now you said you are thinking that maybe it's the cost. Why is it cost effective? And what do we mean by cost effective? It doesn't mean that it doesn't cost. Of course, it costs money. But does the money we are paying goes back to us with an effect or a benefit that is okay, that is better than what if you don't pay this money? Actually, to answer this question, a study conducted in 2016, also 10 years from now, found that testing only CYP genes, only the cytochrome P450 genes, the ones that are most commonly tested, CYP2D6, CYP2C19, and maybe CYP2C9, at elderly patients. And when we are talking about elderly, so you have to think directly about polypharmacy, right? And when you're thinking about polypharmacy, you have to consider how vulnerable these patients and how they can benefit from taking the least number of trial and error. So in these 250 elderly patients, they were matched to non-tested 820 patients. So the total number of study is a little bit more than 1,000 patients. And these 200 proved that pharmacogenetic testing is associated with a saving of cost of around $218 per patient. So the amount of money you're paying for this, or that was paid for this test preemptively, before starting, has resulted in a reduction of the cost of trial and error, of hospitalization due to adverse drug effects, of shifting from one medication to another until reaching the correct medication. It has actually saved money rather than cost more money. So is it cost effective? Yes, it is. Is the evidence there? Yes, it is, and it has been for a long time. And actually, there are more recent studies. I wanted to show you that this is already there. It is already there, and it has been already there for many years. We are not talking about something that we are just trying to prove that it is safe, safer, more efficacious, and also more cost effective. We are not trying to prove this. We don't need to spend time on proving this. This is the main message of bringing these results. So by now, I think you have a little bit of understanding, or a deeper understanding, of the possible impact of